Welcome to CVPR 602 Physiologic Assessment. Well, up till now we have discussed hemodynamics and the hemodynamic parameters that we look at during bypass. We have also looked at oxygen content, oxygen delivery, and oxygen consumption. We've looked at the arterial and venous blood gases and their normal values, and the acid-base status of a patient. And today we're going to continue our discussion, and we're going to talk about adequacy of perfusion, problems with the mixed venous oxygen saturations, the SVO2. We're going to introduce you to cerebral oximetry and pulse oximetry. And remember, this class is all about the ability to assess a patient and determine whether you are adequately perfusing that patient. So adequacy of perfusion, what do we mean by that? Well, it's been stated in the past that that cardiopulmonary bypass perfusion is the therapeutic maneuver causing the most extreme physiologic derangement in medicine. You know, if you think about it, we are mechanically supporting the heart and lungs. We are doing things that our body doesn't normally do. We produce flow that's non-pulsatile. We change the temperatures. We introduce foreign surfaces that the blood comes in contact with. We fully anticoagulate patients. So it can be argued that it is the most extreme physiologic derangement in medicine. And therefore, it is commonly understood that perfusion can never be normal using cardiopulmonary bypass at this stage. It can only be adequate. So our attempts at taking care of our patients is often termed adequacy of perfusion, not normal perfusion. So what do we consider to this juncture of our class? What have we considered to be optimal perfusion in terms of adequacy? And we use things like, is perfusion adequate when our flow rate is at a 2.4 cardiac index? We certainly use that as a benchmark. You add to that a mean arterial pressure being 60 millimeters of mercury, and usually there's a parameter, 60 to 80. Our arterial blood gas, normal. And then we look at the oxygen delivery and oxygen consumption in terms of SVO2. And we like to see an SVO2 greater than 70 or 75% during bypass. And so we started at this level, and then we began to question whether it was enough just to look at these four basic pillars of adequacy of perfusion. Let's look at that SVO2 for a second, and I want to direct you to this paper, and this paper is on Blackboard. It's a 1995 paper. It's an animal study, and I want you to go back and look at this paper. Study particularly these two graphs. And I want to discuss this data in class. I'm not going to go over it now, but these two graphs really spell out one of the primary problems with SVO2 in terms of it not giving the total picture on as far as adequacy of perfusion. So study these graphs. We're going to talk about this. I want you to understand where the problem is in SVO2. But it does lead us, that problem does lead us to adding another dimension to this adequacy paradigm. And that is the flow is coupled to the hematocrit to guarantee that the oxygen delivery is greater than 270 mLs per minute per meter square of the patient. And I know we've gone over that, but I want to emphasize that again. This is becoming more and more understood to be a evidence-based parameter that we can use together with these others. But as we have began to study this even greater, there has been other ideas surrounding perfusion adequacy, and one of them is that there should not be any lactate formation. I'm gonna wait to really discuss this, not in this week's class, but the next week's class. But be it for now that we want to add into the flow ensures that no lactate formation is occurring according to the oxygen delivery CO2 extraction. So we're starting to put together a map, so to speak, that will help guide us during the case. You're behind the pump. You're monitoring all these things. You want to do what's best for the patient. The 70 trillion cells that make up that patient, we want to adequately perfuse them so that the outcome is as good as it can be. And so these are some of the roadmaps. These are some of the markers. These are some of the indices that we are going to use. And this data is going to be continually synthesized as you're on bypass. So one of the new monitoring techniques that has really emerged in the last decade or so is cerebral oximetry. And what makes cerebral oximetry so captivating is that it does overcome some of those issues with some of the more global organic indices of adequacy of perfusion. SVO2 is great, but it's a mixed SVO2. It really doesn't tell us the adequacy of perfusion specific to an organ bed. So if we're monitoring an important organ, the brain, maybe this can be an important adjunct to our monitoring. So again, as we're marching along in cardiac surgery and other non-bypass interventional techniques are emerging, what we have found is that patients are getting more and more high risk. They have more comorbidities, they are older patients, and they are at increased risks of perioperative complications. And neurological complaints are second only to cardiac problems for increasing morbidity in the postoperative period. And this table 1 shows types and incidences of neurologic complications after cardiac surgery. And it's pretty significant. When you look at intellectual and cognitive function, 30 to 79% incidence. And some of this may be transient, but that's a scary number. Again, as patients get older, central nervous system and adverse outcomes can occur. And you can see as the patient age increases, the incidence of stroke rises fairly dramatically. At greater than 75 years of age, 7 to 9%. That is a big number. Neurocognitive decline can occur in 60% at 1 week and between 25 and 30% between 2 months and 1 year. And you'll hear terms like pump head and pump fog, where patients who have just had cardiac surgery using a heart-lung machine will have these neurocognitive declines that are noticeable. There are basically 2 types of adverse CNS outcomes. Type 1, cerebral death, non-fatal stroke, and TIAs, focal injury, stupor, encephalopathy, and coma. Type 2 is deterioration in cognitive function, deficits in memory, and then seizures. And so there is the question of how is this happening? Is the brain injury from embolic phenomenon? Is it emboli? Is it microemboli from the pump? Or is it cerebral hypoperfusion? Is the brain just not getting enough oxygen? Or is it some effect of the foreign surface contact causing a systemic inflammatory response? So this gets us to monitoring the brain specifically, and the EEG, the electroencephalography, can be done. You can do serial measurements of jugular bulb saturations, oxygen saturations. Cerebral oximetry based on near-infrared spectroscopy. And this is a non-invasive technique. So there are wavelengths, 660 and 940. And chromophores like hemoglobin and oxyhemoglobin strongly absorb light in this spectral range, allowing the light to penetrate tissue to a greater distance. Absorption of this light due to other biological compounds in tissues such as water, lipids, skin, and bone is lower in magnitude, and these biological compounds generally have a flat absorption spectra. So here's the biological spectroscopic window right here at this 660 and 940 range. And here you see it. The 660 to 940 range is sort of that window. And you can see the hemoglobin, oxyhemoglobin are present in this window. This is a nice slide, and we're going to get back to this when we talk about pulse oximetry. Pulse oximetry also, and I'll give you a little prelude to that, also uses wavelengths of light to measure saturations. So it has some similarities. You can compare cerebral oximetry to pulse oximetry. Of course, pulse oximetry relies on pulsatile flow, and the wavelengths are generally a little bit different. It's mainly looking at the arterial component in pulse oximetry, where in the brain, when we're measuring cerebral oximetry, it is a ratio of arterial and venous blood, 25% arterial, 75% venous. So cerebral oximetry is neither a arterial nor a venous blood completely. It is a regional saturation. Pulse oximetry is going to be an arterial saturation. Excuse me. So here's the localized area of measurement. These patches that are placed on the head will emit near-infrared light, which will penetrate across the skull and into the surface of the brain. And it's also and this will be reflected back to a detector. And you can see how there is in this particular device, there is a shorter beam that's being detected. This can eliminate the scalp contribution, and then a second emitter that is actually penetrating to the brain. These regional saturations in the blue, you can see this is the cerebral oximetry being compared to the jugular oxygen saturation, and we see a pretty nice comparison there. So what do we do with the data provided by cerebral oxygen saturations? Well, what we can do is develop a plan, an algorithm. What do we do when we have a change in cerebral oxygen saturations? And usually cerebral oxygen saturations that drop below 15 or 20% of baseline, you're going to have a baseline level, really triggers possible interventions. And some of those interventions are shown here. We can increase the FiO2 on the blender to 100%. We can make sure the cannula position is positioned correctly to ensure adequate cerebral venous drainage. Check the head in cannula, venous cannula. If the PaCO2 is less than 40, increase the PaCO2 to greater than 40. CO2 is a potent cerebral vasodilator, which will allow more blood flow into the cerebral region. If the mean arterial pressure is less than 50, increase the mean arterial pressure to greater than 60. If the crit is low, transfuse blood. So these are some of the things that you can do to treat a declining cerebral saturations. The other thing you need to do on the monitoring side of this is to look for bilateral desaturations, and the cerebral sat measurements can be a very powerful safety device to ensure that cannula positions are right. You can have an arterial cannula that subselects an arch vessel and is hyperperfusing regions of the brain. You can have a venous cannula that's not draining adequately from the brain and is undetected, that doesn't show up on a dropping level in your reservoir. And so it can be a very good correlative safety device to ensure that cannulas are positioned well. Now I want to talk also about pulse oximetry, and we talked a little bit about it, comparing cerebral oximetry to pulse oximetry. Pulse oximetry is a ubiquitous monitoring device. Any patient that undergoes any kind of anesthesia is going to have a pulse oximeter. It clips across the finger, and again, it runs on the same principle that there's a window in terms of the wavelength of light, and the absorption of light at these two wavelengths by hemoglobin differs depending on whether that hemoglobin has oxygen bound to it or not. The light signal follows a transmission through the tissue and has a pulsatile component. So pulse oximeters measure oxygen saturation of the hemoglobin in the arterial blood. And they also measure pulse rate in beats per minute, averaged over 5 to 20 seconds. So they provide a couple of nice data points. First of all, what is the saturation of the arterial blood reaching the periphery, like on a fingertip, and what is the pulse rate? So it gives that data. It doesn't really tell us about oxygen delivery. It doesn't really tell us about oxygen consumption, but it does tell us the oxygen saturation of the blood reaching the periphery. So again, pulse oximeter gives no information on the oxygen content of the blood. It's not telling us what the hemoglobin level is. It's not telling us the amount of oxygen dissolved in the blood. It just gives us a rough idea. If it's 100%, we know it's a PO2 of 90 or above. It doesn't tell us about respiratory rate or tidal volume. It doesn't give us any ventilation data. And it doesn't tell us the cardiac output or blood pressure. But it is a very important piece of information preoperatively and postoperatively. And when we go on bypass, pulse oximetry is not so meaningful because we generally do it with non-pulsatile flow. So thanks. I look forward to discussing these aspects. We'll talk about adequacy. I do want you to study that paper on the problems of SVO2. And let's get ready to have a nice discussion about synthesizing all these elements in a meaningful way when we're operating the bypass machine. Thank you very much, and we'll see you.